Good morning, good afternoon, good evening. I'm Rika Jolie, head of the Global Swine Marketing Team at MSD Animal Health. It's my pleasure to welcome you to another educational webinar that will be presented by Dr. Khan. But before introducing our guest speaker, let's just imagine the following. What if we could know about the next infectious disease before it appears in our backyard? What if existing databases could actually be used to do just that? Could this prevent the next pandemic? Or could it at least improve our response to any new infection? So this is where Dr. Kamran Khan and his team come in. Dr. Kamran Khan is an infectious disease physician scientist and a professor of medicine and public health at the University of Toronto. He was on the front line of the 2003 SARS outbreak in Toronto. And this is what motivated Dr. Khan, who had been studying outbreaks of emerging and re-emerging diseases for more than a decade, to use his knowledge to develop a global early warning system for infectious diseases. In 2003, Dr. Khan founded BlueDot, a digital health company that combines epidemiology, human and artificial intelligence to predict how disease moves. At BlueDot, they have built a digital global early warning system for infectious diseases. And this system has been applied already to various outbreaks, just to name Zika, and then also SARS, and then more recently, the current COVID-19 pandemic. With that, I will transfer to Dr. Khan to present his seminar, Our New Reality, the Need to Spread Knowledge Faster Than Epidemics. Before transferring to Dr. Khan, just a couple of housekeeping items. This seminar is also available in Chinese, Spanish, and Russian. I believe you have to look at the flags that are on your screen to follow the translations. And then after Dr. Kamran finishes the presentation, Dr. Mikel Koye from the Global Marketing Team will entertain the question and answer session. For the questions, you can answer your questions online in the system and we will receive them. So with that, Dr. Khan, I will leave the video to you.
Thank you very much, Rika, and really appreciate your invitation for me to present today. Okay, well, first of all, again, good morning and good afternoon, good evening, depending on where you are. Very much appreciate the opportunity to be presenting to this group today. I'm going to be speaking about some of the challenges that we are facing in our rapidly changing world with respect to the emergence and spread of dangerous epidemics. As Rika had mentioned, I wear a few hats. I'm a practicing infectious disease physician, still continue to work in a number of the teaching hospitals here at the University of Toronto, where I'm a professor. And as Rika mentioned, it was actually in 2013 I founded BlueDot, and we are a digital health company that I will tell you a little bit about during this presentation. Now, I will make a bit of a disclaimer that I'm not a veterinarian. I don't come from an animal health background, although a number of our staff at BlueDot are veterinarians and veterinarian epidemiologists. But I do hope that you will find, some of the presentation that I am sharing today is at least transferable and certainly pertinent to epizootics and outbreaks of animal pathogens. So let me just start out by taking you back 17 years to 2003. And this is really where my interest in this entire field of emerging infectious diseases began. I was just finishing my training in infectious diseases and preventive medicine and public health. Was living in New York at the time, returned back to Toronto, which is home for me. And shortly after I got back to the city and was literally starting my career at one of the teaching hospitals, this virus that nobody had ever seen or heard of before showed up in our city and in our hospitals, infected a colleague of mine, and led to the deaths of not only some members of the public, we had 44 deaths, but also a number of frontline healthcare workers. Of course, that virus, we now are very familiar with it, which is the SARS coronavirus. And it was really a eye-opening experience to see how this little virus could cripple an entire city. Our hospitals were overwhelmed, our public health system was overwhelmed. People stopped traveling to the city, which had profound economic implications, especially in the travel and tourism and hospitality sectors. And that outbreak went on for 4 very, very long months. So that was really an experience for me that highlighted that while the world had never seen anything quite like this before, that this wouldn't be the last time. There was a realization, of course, at that moment that epidemics spread incredibly quickly. Now, as someone trained in public health and clinical infectious diseases, if I didn't know about SARS, I'm not sure how anyone else would know about this. And just in a matter of days, this virus spread from Guangdong province to Hong Kong, and then ultimately to a number of countries around the world and cities, including Toronto. So we live in a very interconnected world, but we're also in an interesting period in time where the world is changing in ways that could play to our advantage. We have increasing access to big data. We have advanced analytical capabilities like machine learning and artificial intelligence. We have high performance computing capabilities in the cloud. So we actually have, in many ways, the raw materials and the raw ingredients to be able to spread insights and knowledge faster than diseases themselves can spread. Now, in order to actually operationalize this principle, we really are going to need more advanced early warning systems for infectious diseases. And that was my personal mission back after the SARS outbreak, when I spent 10 years as an academic studying emerging infectious diseases, but then in 2013 founded BlueDot. And the purpose here was that perhaps we could bring together a diverse mix of expertise, not only in the subject matter of infectious diseases, but data analytics, epidemiology, data science, software development, engineering. And we could bring all these different diverse skill sets together to begin building this early warning system. Now, I'm going to walk you through some of the pillars of what we have been building for the last 7 years. We tend to call them the 4 Ds, and I'll walk you through them. The first is detection. If we're going to be able to prevent an outbreak or at least mitigate its impacts, we are going to have to detect it early so we can buy ourselves valuable time. The second pillar is to understand patterns of dispersion. Outbreaks are not like earthquakes, where they generally are localized to a particular geographic area. They jump across continents and can do so in days or even hours. And so how do we ultimately understand how pathogens can disperse? Now, in my world, in human health, we often think about humans that are the vectors for the spread of diseases. That may be true in some cases with respect to transporting animal products, but there may be other mechanisms by which animal pathogens can disperse. And the third D is really about disruption. We know diseases spread around the world all the time. I see this in my clinical practice with people returning from different parts of the world with infectious diseases, perhaps not as frequently since COVID-19, but all of those various events don't lead to outbreaks. And so what are the characteristics, and can we anticipate when dispersion of a disease will lead to secondary chains of transmission and ultimately trigger an outbreak? And then finally, how do we get that knowledge? How can we generate knowledge in a way that's tailored to a particular audience, to a particular geographic area at a particular point in time, and disseminate those insights in a way that empowers the organization or the individual to take actions so that they can better protect themselves, their organization, and really the world around them. So I'm going to actually talk a little bit about not just these 4 pillars, but ultimately the fact that these pillars need to be deeply integrated. If you have a detection system that is not connected with a system that is thinking about dispersion and disruption and dissemination, you're going to lose time. So how do you quickly get from detection to dissemination of insights? So I'm going to walk through each of these 4 pillars. Given the interest of time, this will be about a 45-minute discussion. I'm going to take this at a fairly high level, but happy to take questions at the end of this presentation. Now, let me just start out with respect to detection. I think one of the first things that we started to do was to digitize endemic disease maps. Now, as an infectious disease physician, one of the challenges I know I face and I know my peers face is that there are a wide variety of maps that are out there of yellow fever and dengue and malaria and chikungunya and typhoid and so forth. But the way that we generally access this information was we look at a picture. Maybe we go online to the CDC website or the WHO website and we look at an image. Or maybe the data are actually in a tabular format or some other form that are not necessarily all that easy to fully make use of. And so our team of GIS specialists, as well as our epidemiologists, have reviewed the latest data and the latest in the scientific literature on where these diseases are active. What is their geographic distribution? What do we know about levels of transmission and activity? And turn these into spatial maps that we've then put APIs or application programming interfaces around so that we can actually use technology to talk to the data, so that an individual can just simply ask the question. My patient was, let's say, in Mumbai 7 days ago. What kinds of diseases might normally be found in that geographic area? And this is because humans have a difficult time remembering all of these various maps. And we don't have them centralized in a way that is readily accessible. Beyond just looking at disease endemicity, we're also using AI and machine learning to detect global epidemic threats in near real time. We recognize that we need to understand that outbreaks can appear suddenly, and how do we become aware of them as early as possible. And this is where our team of data engineers and data scientists and subject matter experts have been working together. First of all, to extract information from official reports, not only from groups like the WHO or the CDC or national public health agencies, but also to gather this information from the animal health community, such as OIE and FAO, where there are news of outbreaks involving animal pathogens. Some of those are zoonoses and can certainly spill over into human populations. On the other hand, we're complementing this surveillance data with unofficial information that is coming from the internet, coming from the world's online media, from health forums and blogs that the healthcare and public health community participate and contribute to. And we've been scanning for news of over 150 different diseases, currently gathering the information in 65 different languages, and we're doing this every 15 minutes around the clock. This is important because, as we know and have really learned, that sometimes official reports of an outbreak don't necessarily come as quickly as we would like them to or need them to. And so the unofficial sources of information can be complementary and perhaps offer us a more timely view into a potential epidemic threat that may not be officially reported. Now, to process all that information, it's a vast amount of information, and this is where things like natural language processing and machine learning come into play. And so our data scientists have developed algorithms that can process all of this information and understand the context. So if we're dealing with an article that has the word anthrax in it, it may be referring to the heavy metal band anthrax, or it may be referring to an outbreak of anthrax. But ultimately, we have used machine learning and essentially trained this machine to start to separate the outbreaks that are about actual pathogens that we want to be interested in from those that are of irrelevant information, as well as removing duplication of information. We ultimately extract then the pathogen, the place, and the time, and other contextual data. So we can turn this vast amount of unstructured text data into structured data that has a location and that has a timestamp associated with it. So now we can start to make use of it in a more meaningful way. And in fact, this system was scanning the web on December 31st and picked up an article in Chinese, translated it, identified some unknown cases of pneumonia. There were a few keywords in there about SARS, and our system flagged this information, excuse me, to our team of epidemiologists and subject matter experts, excuse me, on the morning of December 31st. So we were able to review this and add some context that a machine wouldn't be able to possibly do. What we recognized when we saw this early warning was that there were some parallels with the SARS outbreak 17 years earlier. This was an outbreak involving a pneumonia of unknown etiology. It seemed to be centered around this animal market. This was occurring in Hubei province, really just north of Guangdong province, very similar to the way things got started with the SARS outbreak. So we didn't know at this moment that this would turn into the next pandemic, but we were very aware that this was an outbreak that really warranted our close attention. Now, I'm going to shift from talking about surveillance to talking about how do we connect a local outbreak to understanding how it may spread, and how do we do this in a way that's scalable. Now, when it comes to dispersion, for any given outbreak, here I'm just showing what happened in the back end of our technology during the early days of the COVID-19 outbreak. That blue pin there is the location of the outbreak. And these circles are the locations of neighboring commercial airports. So we have been using modeling techniques that are using friction surfaces to identify how long it takes to, and how easy is it to travel to different locations. How easy is it to travel to the nearby airport? So you can see there, red is the location of Wuhan's international airport. There's a high probability that if there was a traveler moving from that epidemic, that would be a place that they would likely go. The circles in yellow are ones that were perhaps a little bit less likely, but also possible. And the circles without any color in them are nearby airports that could be driven to, but have a very low probability of a traveler going to those locations. And these are using gravity models with friction surfaces. That could be an entire discussion unto itself, so I'll keep it fairly high level for right now, but it does give you an indication of how we can connect a local outbreak to an understanding of how infected individuals might jump on an airplane and travel to another part of the world. And that's ultimately how diseases can spread really, really quickly, is through commercial air travel. Now, one of the things that we did during the earliest days of the COVID-19 outbreak, actually even before it was known to be a coronavirus, was we had connected the location, as I just showed you, of the outbreak with the locations of neighboring airports. And this is all happening in an automated fashion. We're then connecting to the passenger level flight itineraries. These are anonymized, of travelers going to destinations around the world. These include the full route itinerary, so the connections, et cetera, to the final destinations. And we're also looking at all the flight schedules and analyzing those around the world. These are coming from the commercial airline industry. And so you can see within just a few seconds of detecting that outbreak, having our internal team qualify it as a potentially, an important outbreak, we can then, within a few seconds, identify all the final destinations of travelers, where they're most likely to go, where the nonstop flights, et cetera. And so you can see most of the travel in this map out of Wuhan at the end of the year was in the area in Southeast Asia and Northeast Asia. But you can see some nonstop flights into places like Italy and France and the UK. Also, if we're looking further towards North America, you can see San Francisco, which is where to date, the first known death from COVID-19 occurred, in Santa Clara County, as well as nonstop flights into New York. And we see these types of outbreaks appearing around the world every single day in our platform, but we were sufficiently concerned about this event that we actually decided to publish this in the scientific literature. And you may remember this started on New Year's Eve day when most of us were planning how to, ring in the new decade. And so we submitted this to the scientific literature for peer review. You can see even from the title, this is before we knew a whole lot about this. This is a pneumonia of unknown etiology and the potential for international spread through commercial air travel. What we had identified, as I showed in that map, were the locations that seemed to be most connected and perhaps most susceptible to the importation of this particular outbreak, if it in fact started to spill out of Wuhan to other areas. Now, when we first analyzed this, there were only 27 cases being reported, but we had concerns about whether that might be the tip of the iceberg. Maybe the outbreak was actually bigger, or perhaps maybe it would become bigger. And so you'll see here the red dots that I've highlighted on table 1 are identifying the cities that were among the first to actually receive imported cases of COVID-19 as it spilled out of mainland China. You'll see Bangkok there at the very top of the list. And in fact, Bangkok was the first city that received a case of COVID-19 as it spread out of mainland China. So this was a way to identify the patterns and anticipate the patterns of spread. And in fact, COVID-19 largely followed the distribution of geographic locations identified here. This, just by the way, was not something that we did in retrospect. This is actually something we submitted on January 8th, back at the beginning of the year. So I want to shift and talk a little bit about, how people may move out, not necessarily using commercial air travel. This article was written a few years ago in 2015, and at the time, 2020 sounded like it was so far off into the future, but here we are. And it's estimated that, about 80% of adults around the world have a smartphone in their pocket, not just a mobile phone. And one of the things that we have been doing is working anonymously, and I do want to underscore anonymously and sort of adhering to all the privacy regulations on analyzing location data for almost 400 million mobile devices around the world, and doing that in near real time. So I wanted to show you here of some of our analytics looking at mobile devices that were in the Wuhan area and then where they appeared in the next 14 days. So you'll see here, this is Wuhan, and then you will see some of the international locations out of Wuhan where those devices subsequently traveled. And these are places like Tokyo and Seoul, Shanghai, Taipei and Kaohsiung in Taiwan. You've got Shenzhen and Hong Kong, and even Bangkok down here. And these are, again, some of those cities that were among the first that receive imported cases of COVID-19. So it's another way, day by day in the month of December, we're looking at how those devices are moving. So I'm going to now talk a little bit about thinking about seeding and having these potential travelers transport an infection. But as I mentioned, not all dispersed infectious disease leads to a secondary outbreak or causes disruption. To really understand that, this is difficult work. This is where we need context around each pathogen to understand, well, if we had Zika virus spread into Toronto, would that lead to a secondary outbreak? What if Zika virus spread into Miami or in Sao Paulo in Brazil, for example? Could it lead to a secondary outbreak? And of course, this is where we come to the epidemic triangle. And we understand that disruption and ongoing impact is really a function of the attributes of the pathogen, the susceptibility and characteristics of the population, and the environmental conditions. And so really, it's the confluence of these different factors that could lead to some sort of impact. But of course, for every single pathogen, you've got a different footprint. Zika would behave differently than COVID-19, which would behave differently than cholera, which would behave differently than any other pathogen. And so this requires a very diverse set of data on outbreaks and on infectious disease activity. But we have to think beyond just simply travel. We need to understand things like demographics, perhaps animal populations, vector distributions, climate conditions, health system capacity, and all of these various data sets have to then be subsequently integrated. Now, in some ways, it perhaps sounds like it's a fairly simple thing. We take these data, we start to kind of mash them up together, but ultimately, these are diverse data that weren't necessarily intended to be integrated with one another. So I'm just showing an example of how, if we wanted to layer all these data, we would need to do so using GIS technology and recognizing that the spatial units may not necessarily align. So if we were thinking about a vector-borne disease, we might need to understand, well, where have ticks been identified? We may need to understand, well, where have cases of a particular disease that is tick-borne been identified? We may want to understand things like hiking trails and where individuals are walking and going through these areas. We may need to understand things like vegetation using perhaps satellite or terrestrial sensor data, elevation, temperature conditions, precipitation, and so on. And so all of these different data sources have to be integrated by place and time. And that's a pretty formidable fact because, as I mentioned earlier, many of these data sources were never intended to be integrated. And so this requires quite a bit of work using GIS technology or technology that is based on geographic information systems. I've highlighted here, it's not just about spatial data integration, but it's also about temporal integration, because these various units and these geographic data are also changing by time. So I'm going to just show you a visualization of some of the manners in which these data are changing, not just by place, but by time as a visualization. So here we're looking at the movements of travelers into London. These are the bars that are going up and down. And on the base, we're looking at the world's temperature. So you're seeing seasons, an entire year, go back and forth between temperature. So these are just two dimensions of data and how they are changing by place and time. So there's a considerable amount of underlying computing and GIS work that needs to take place to integrate all these diverse data sources. I'm going to just share an example of how some of these diverse data sources came together to understand the so what. Where is the impact potential? Going back to perhaps our last major global public health crisis, the Zika epidemic that spread rapidly through Latin America in most of 2016. And what we did here was we took surveillance data on cases of Zika virus that had been recognized mostly at that time in the northeastern parts of Brazil. We used Aedes aegypti occurrence data to create a surface distribution of where the mosquito was perhaps most likely to be present. We coupled it with climatic data to develop a model to estimate, well, where would Zika virus transmission most likely occur? And where would it occur perhaps more sporadically based on climate conditions, and where might it occur year round? The areas in dark orange are the places that were most optimally suited for Zika virus transmission based on temperature conditions, which is a key factor in the life cycle of the mosquito and its ability to transmit to humans. You'll see here we overlaid these dots. These dots are the locations of commercial airports that fall within 200 kilometers of one of those dark orange areas. And then ultimately, we took all of the analysis of travelers leaving those locations for destinations not only in Latin America, but around the world. And you'll see here, this is looking at the Americas. And the circles represent the final destinations of travelers coming from areas in Brazil, which were perhaps optimally suited for Zika virus transmission, and where they may be most likely to be viremic and introduce Zika virus into an area where they would then infect a mosquito locally that would then have the suitable climate conditions to be able to further propagate the disease and lead to an outbreak. So what you will see here is that the arrow is highlighting a large number of travelers coming into parts of Florida, which you'll also see beneath in dark orange is an area that is certainly has the capacity from a climate condition perspective to catalyze an outbreak of Zika virus. And in fact, this is actually what happened. We published that in January of 2016, actually prior to WHO's declaration of a public health emergency. And 6 months later, we did have a local outbreak of Zika virus occurring in Miami, as some of you may remember. We actually looked at this as well, not just in Latin America, but looked at this across parts of Africa and other areas of the world. And here we're looking at the same issue around susceptibility to Zika virus transmission based on the presence of Aedes mosquitoes, as well as suitable climate conditions. Now you'll see here this large circle around Luanda, and it turns out that Luanda is the main gateway from Brazil into Africa. As some of you know, Angola is a former Portuguese colony, and certainly there are those historical ties between Angola and Brazil. And so what you'll see here is we actually looked at this now on a month-by-month basis and how temperature is changing. The dark areas are the areas that are most suitable, and you'll see how this oscillates from month to month. One of the things that we initially were concerned about was introduction of Zika virus into Luanda in and around April or so, and then subsequently around November as the climate conditions started to change. What we did ultimately subsequently realize is while there weren't reports of Zika virus outbreaks in Angola, about 10 months, roughly, the period of a gestation of a pregnancy, some first cases of microcephaly were being reported in around January to February of 2017. That's again about 9 to 10 months after March and April of 2016. And then subsequently about 9 months or so after October to November, we start to see also another rise in cases of microcephaly. So these analytics seem to be supportive of the climate condition analysis around when Zika virus might be introduced through commercial air travel, when the ecological and environmental conditions may be suitable to catalyze and trigger an outbreak. And subsequent genetic analysis, phylogenetic analysis, is identifying that the strain of a Zika virus that was circulating in Luanda was in fact very, very similar to the strain that was identified in northeastern Brazil. I'm going to shift to talk a little bit about resiliency, another aspect of impact. This is a framework that the RAND Corporation had published a few years ago in the scientific literature, looking at the 7 different domains and how they may influence the resilience or vulnerability to an infectious disease outbreak. Some of them include looking at the healthcare workforce, the public health infrastructure, economics, disease dynamics, demographics, political factors, and so forth. And so what we've also been doing is curating these roughly 50 different indicators, compiling them and integrating them into these vulnerability indices, and mapping this now out at a subnational level. The earlier work published in the paper that I just showed was mapped largely at a national level and not necessarily being continuously updated and dynamically updated. And this is where we have been gathering and analyzing these data to provide a better understanding of the vulnerability of these locations to respond to an outbreak. There have been a number of these types of indices that have started to emerge in recent years. So I'm going to shift gears and talk a little bit about some of the past disruption. Ultimately, how do we then disseminate this knowledge? How do we quickly get it into people's hands so that they have the information in a timely manner and can respond to it? So here is one of the challenges that I think we face today, which is that information tends to flow in a waterfall approach. Government, typically the public health agencies, because it is part of their core mandate, is they first hear about outbreaks because they're actively looking. The information, and I know this still as a practicing frontline healthcare worker, it tends to trickle down a little bit to the healthcare sector next. And I say this even thinking about COVID-19 and in the early days of the outbreak, just even talking to some of my peers, they had not actually heard about Wuhan and didn't know what was happening there. And that, of course, is a problem because sick patients don't go to the public health department, they wind up in the emergency department. And of course, it's critical that your healthcare workforce is aware of what is happening. That's challenging because the healthcare workforce tends to have a myopic view of infectious disease activity because their responsibility is to be managing a large volume of patients that are in front of them. The information tends to then trickle over to the private sector, and then finally, the public tends to learn about it next. We've always felt that this is not really the ideal way for information to flow, and really what we need is a more contemporaneous system where we have information flowing to population health custodians, whether they happen to be in the public sector, in government, or whether they happen to be in the private sector. These could be global businesses that are thinking about business continuity, that are concerned about supply chains, the safety of their employees or their customers. That is one key audience that we really need to be empowering. The frontline healthcare workers, for the reasons that I mentioned earlier, critically important that they have the knowledge to be able to protect not only themselves from a patient with a dangerous communicable disease, but also to protect the patients and everyone in the hospital and in their local community. And then finally, we have healthcare consumers who are the general public, and ultimately we need to be putting the public front and center in our public health efforts. So I'm going to just share a little bit about a few pieces of technologies and how have we tried to communicate insights across multiple different perspectives. We all have the same goals in mind about protecting ourselves and minimizing the impacts from an infectious disease, but ultimately how we see the world is very different if we happen to be in government or in industry or a frontline healthcare worker or a member of the public. So how have we been using technology to try and reach these audiences? So I want to just share how we have been building global software systems and online applications here to map out infectious disease activity. So what I described from the early warning system, mapping out infectious disease activity, not just this here, we're looking at COVID-19. This is from months ago, and looking at the number of cases and deaths and doing this at a subnational level. But ultimately, also doing this for all of the other infectious diseases, whether it's an outbreak of dengue or typhoid or some unknown illness, and to have all this information mapped out centrally in a digital online dashboard that anyone can access. The information, of course, is not only about the surveillance, but all of it is fully integrated with the world's commercial air travel data. The passenger level flight itinerary data, as I mentioned and described earlier. So this gives us that global view. Now, how do we take that global panoramic view and understand, well, what does it mean for me? How do we make it more local? So what's happening in the back end here in this dashboard is that for every outbreak in every geographic location, we can immediately notify users of the system if the outbreak happens to be in their backyard. If it's within 100 kilometers of them, we'll immediately notify them that there is this particular event taking place. But what if it actually isn't in their backyard? And as I described earlier, we can connect the location of the outbreak to the locations of neighboring airports and the probabilities that people would use those airports based on how far they are, how easy they are to travel to, the size of the airport, and other factors. And these are using some of the spatial analytics that I described earlier. We can then connect all of the travel data on the nonstop flights, the final destinations of those travelers, and based on the size of the outbreak as it's reported, and the volume and flows of travelers, we can come up with an estimate of how likely is it that that particular outbreak is going to show up in your geographic area. And we can do this for every commercial airport in the world. There's about 4,000 roughly of them. And we can do this for every single outbreak that is appearing in the world on any given day. And so this really gives us the ability to, within seconds, be able to have an understanding of any emerging threat around the world and what does it mean for my geographic locations of interest, whether or not they happen to be in my backyard or whether I happen to be halfway around the planet. And so you can see here, this is, I'm just going to point out to the left-hand side of this map here, this is where you'll see it says my locations, where we allow users to actually enter the locations that they're interested in. It might be their country or a state or province, or it may be that they've got different locations and hubs located around the world and they're non-contiguous geographic locations. What diseases are you interested in? You may only be interested in vector-borne diseases or animal pathogens, or pathogens that could have security implications or be weaponizable and so forth. And here we're just looking at COVID-19, where you can now only look at the spatial geographic distribution, but also understand the temporal aspects of all of the data as well. So this is a way to kind of bring all the pieces together. I'm going to shift gears and talk a little bit about now going from global to local. And this is where during the COVID-19 outbreak, we started to work with the mobile device location data, again, analyzing data in an anonymized, aggregated manner. And here you will see these are mobile devices that moved outside of their home location. And so home locations are calculated by assessing where the device resides between midnight and 6 in the morning, generally where people tend to be sleeping. And then ultimately, if the device leaves that area, where does it go to? And this is looking hour by hour across the city of Los Angeles to see to what extent are devices leaving those locations. This is during the early days of the stay-at-home orders. The blue circles tell us that these are areas where the number of devices has decreased compared to the previous week. And the red circles are areas where the number of devices has actually increased. And some of those were grocery stores or hospitals. Some of them were playgrounds and other locations to be able to generate that kind of public health intelligence. These types of analytics were being generated across the US and we continue to do so today, as well as Canada, to generate this type of public health intelligence. There are other applications I won't spend a lot of time on to understand if populations are crossing an international border. These are not using cellular data or cell phone data. These are actually using GPS data, so we can follow devices as they move across international borders, as I showed earlier with the instance of Wuhan and the devices moving across Southeast Asia. We can look at areas of interest where outbreaks may be occurring to understand how populations may be moving, to help facilitate better understanding of contact tracing, where to increase surveillance capabilities, and so forth. So there's a wide array of potential uses of these different types of high spatio-temporal resolution data to support public health decisions and actions. I'm going to, in the interest of time, I'm going to shift gears a little bit and start to talk now about the actual medical provider and going from the broader global panoramic perspective to understanding what's happening in a local community to now empowering the frontline healthcare worker. Now, there are two ways, I think, to do this. One is anticipatory education. Give us a heads up that there is an outbreak, let's say, of a pneumonia of unknown etiology in Wuhan because we're in the middle of flu season. And if we see something, we're going to probably just assume that it's influenza, but we should at least be aware of what is actually taking place. It may be much simpler than that. It may be that there's an outbreak of mumps in our, community, and we actually don't know about it because we're so focused on our day-to-day clinical work. So getting that intelligence to us in a meaningful and timely way. And the second is smarter triage. Every time a patient comes into the emergency department, they're going through a triage system, which may or may not ask about travel history. I think that is probably going to be occurring with much greater frequency now in a post-COVID-19 world. But ultimately, how does the frontline healthcare worker or the triage nurse know everything about every outbreak and every endemic disease and its geographic distribution around the world? The reality is that most of us have not actually received a whole lot of training in this. During my medical training, and probably for most other physicians, we get about a half a day to a day of tropical medicine in our entire medical career. So how do we actually do that in a smarter and safer way? Now, when we think about anticipatory education and sending you a notice, if we do this in a way that is unfiltered, we will quickly overwhelm you. There's so many different events happening around the world every single day. Your inbox, or you will just get so many notifications that you're quickly going to lose sight of what's important. And this is really how, as I described earlier, how we're using the spatial analytical capabilities to connect the location of an outbreak to the locations of the user, either in Euclidean space if they're nearby, but also to connect it to the global airline transportation network data, and ultimately give you a sense of you're in the path of this potential outbreak, and it's particularly important that you know about it. The other challenge that I mentioned earlier is this adage in medicine. Now, this clearly was coined by an American physician, not someone in Africa, but the adage goes that when you hear hoofbeats, think of horses, not zebras. This term was coined more than 70 years ago, and it really is just to say, think about common things. Don't think about unusual types of diseases, because it's more likely something that's common. And that may be true, and may have held up well in 1948. It doesn't necessarily hold up very well in 2020, when we have these metaphorical zebras kind of moving all around the world on such a regular and common basis. And the last challenge is that we just don't have enough trained staff who have these types of expertise. There's a relatively small proportion of clinicians that are trained in these areas. And so ultimately, we need to be creating more astute clinicians. How do we empower clinicians to be able to protect themselves and the world around them? So what I'm going to just share here is a bit about how we actually take the data that I've described to date and empower the frontline healthcare worker, where we're taking all of those endemic disease maps that I mentioned of things like malaria and typhoid and chikungunya and so forth, and then having the geographies turned into spatial data, and then ultimately overlaying it with all of the various outbreaks and threats that are appearing around the world, and incorporating pathogen attributes. Well, what kind of disease is this? Does it cause neurologic manifestations? Does it have cutaneous manifestations? What are the incubation periods of the various diseases? Things that most of us wouldn't necessarily remember. And using and engineering it in such a way that we can put application programming interfaces. And this is basically just kind of like, you just imagine data is water and APIs are the straw between you and the water. So you can actually go in and make queries and extract information. So if your patient happened to be in Dhaka in Bangladesh, and then they ended up going to Hong Kong, and then they went to Sao Paulo and came back to Toronto, that's pretty hard for clinicians to be able to assess what types of diseases and illnesses they might have, and to be able to make sense of it all, not only in terms of the endemic diseases, but is there something happening in that geographic location right now that I should be aware of? And secondarily, what if my patient is going to that location? What kinds of infections should I consider? How do I get myself prepared so that I'm preventing an illness if I go to that geographic location? And so we've been working on building up an application to kind of do this. It starts with the person's travel details and times, starts to map out all of the things like activities that they were engaged in, the onset of symptoms, the clinical manifestations, their vaccination history, and then starts to come up with a differential diagnosis of the things that are most likely to be occurring, as well as some other potential considerations that are perhaps less likely, and then really just to empower the clinician to say, here's why this particular disease is one that maybe you should consider. We're not here to be prescriptive. We're here to empower and support the clinician to help them make sure that they don't forget about a particular disease that maybe they've never seen before, and possibly maybe they've never even heard of before. And so this is an ongoing area that we are actively engaged in. Now, I'm going to leave you with this. I love this sentiment here from the Talmud about whoever saves a single life, it's considered as if they have saved the entire world. I think it's a very pertinent adage at this point in time as we think about the pandemic. And it really only takes one of us to start a pandemic. So if we are able to really empower individuals, we may be able to, in fact, actually prevent the spread of an outbreak. And this is an area that we are also actively involved in and have built a prototype application that can take information about global infectious disease surveillance and then ultimately personalize it to an individual should the individual choose to and opt in to share information about themselves, perhaps their age or gender, if they're pregnant, if they have any underlying health conditions, their vaccination history, and it's left at the discretion, of course, of the user. But here, this is a way that we can actually take infectious disease surveillance, merge it with an understanding, a deep understanding of the subject matter of these various diseases, who would be at highest risk. A pregnant woman may have a very different set of risks than a person who is diabetic in their 60s or someone who is a young child at 3 years of age. And so the whole world will look different to all these various groups. So I'm going to wrap up here and just kind of bring this back to the systems that we've been building around our so-called global early warning system, about the underlying technology that we have, the technologies and applications that we have been building, and then sort of bring it back to, well, how did these actually play out with COVID-19? So I think one of the first things that we were proud of is, as we had built this system, we had detected this event in Wuhan back in late December, and were among the first in the world to pick up some of this information. But we had also taken a step further and actually fully integrated within just a matter of a few seconds and had disseminated this information to all of our various clients around the world on the potential pathways of dispersion using data from the commercial airline transportation network. We also, because we didn't have access to distribute this to everyone, we published this in an open access peer-reviewed scientific publication so that the information would be available to anyone who needed it. As the virus started to seed in different geographic locations and as it reached its peak, we started to use mobile device location data to understand things like social distancing and to inform public health decisions in a way that were precise and targeted and making optimal use of finite public health resources. We are now, depending on the country, starting to move towards a bit more of an economic recovery and starting to reopen society. So we have a different set of needs here. But this is now thinking about repeat introduction. Despite the fact that we've had large outbreaks in many parts of the world, we're nowhere near herd immunity. We still have a lot of susceptible individuals. And so reintroduction of this virus could catalyze a next wave. And we are starting to see this in some parts of the world. And of course, that poses another set of challenges. So we now need to be not just looking in our backyard, but to be looking over our shoulder to other areas that may be hotspots within our own country or in other parts of the world as we start to gradually begin to reopen the world to travel. And then finally, as we look ahead to the future, ultimately, what we are trying to do with many of our partners and clients, which span government, in public health, in defense, in security, which also span the private sector, as it relates to enterprise risk management, thinking about business continuity disruption, impacts on supply chains, the health and safety of employees, as well as healthcare institutions and hospitals, as I described earlier. How do we use this opportunity to build resilience? Because we know that COVID-19, like SARS, we have never seen anything quite like COVID-19 before, but there, unfortunately, we do know that this will not be the last time, and there will be future outbreaks that could be highly disruptive. And ultimately, we need to use this opportunity to be preparing for those even while COVID-19 is taking place. So I'm going to wrap up here and just summarize with a few key points. Global epidemic threats, and I perhaps also should say, global epizootics. These are increasing in frequency. The scale are becoming larger as we see. COVID-19 certainly has crippled the planet, but we've had many other outbreaks, SARS, that have affected multiple different countries, Zika, chikungunya, the Ebola outbreak in West Africa. There are a multitude of these types of threats, and they are increasing in frequency and scale and impact as the world is rapidly changing. We need more advanced early warning systems, and not just ones that are focused on surveillance to identify a threat, but what does that threat mean to me? And how do we end out pushing and presenting this information, empowering individuals within hours versus within weeks or longer? Building and maintaining such systems is something that we've realized is challenging. There are 70 of us roughly at BlueDot. And as I said, we're a mix of physicians and veterinarians and ecologists and epidemiologists, data scientists, engineers, software developers, designers. This requires a very cross-functional approach to be able to build these types of systems and then ultimately to operate and maintain them on an ongoing basis. There is a lot more work to do, but there's a lot of latent potential in the data that we already have access to that we can be making use of. And finally, I just would like to recognize in the audience that I'm speaking to is that the systems that we have developed could be transferable to animal pathogens. And this is where ultimately, I'm not a veterinarian by training, but would love to hear from all of you as to where there may be potential use cases for this type of technology as it relates to animal diseases and epizootics. So let me just wrap up here and just say thank you for having me here today. I've left my email address in case there are follow-on questions that people might have.
Thank you. First of all, thank you very much for this really nice presentation. I think that not personally, but for what I see now, the audience, I think that they enjoy a lot. So first of all, Dr. Kamran Khan, thank you a lot for this nice presentation.
Thank you.
Saying that, I want to apologize for some technical issues that it's been going through the start of the meeting, which I think that at the end they were solved. But I think that you will have also the chance to see that not now direct, so you have the chance to see that in another time. So please, the ones that they were having these problems, you can do that. Well, I have several questions here that the people they were sending to me, but I just want to do a short summary on what you've been doing. So we've been going through the explanation of what this digital health company is doing from the really very start that the doctor was sharing with us. I think that was nice to know this beginning with the SARS coronavirus, that everything was starting there. Nice idea about these 4Ds, the detection, dispersion, disruption, and dissemination. And nice insights of each of these points that they were giving a lot of different things. And well, following and keep going with this, you were talking about how you are doing to digitalize the endemic disease maps, and how these artificial intelligence, they help to do all these kind of things. And even I think that it was interesting to see this Zika model that they will help to anticipate this international spread of that, no? And also I think that was really very interesting to see this connection in the airports and how these airports connection, they were giving insights and a lot of information about that. And finally, the use of these different apps and what you were sharing with us, that I think that it will be the future, how the mobile phones, they were helping to do a lot of things. And you will see that some questions will go into these directions as well. Mm-hmm. So I will start with the first question, that there are a couple of people that they were at least mention of that. So considering that a lot of this model is based on what it's airlines movements and things like this, so in which way that could be good also to help to work on animal health? Mm-hmm. I assume that, well, mainly the animals, they are only a few they are going by plane, so it's the ones that they are having genetic companies, they are moving animals from one place to the other one. But what do you think, which is the challenge, and what do you think about that? So this is the first question.
Well, thank you for that question. And let me just say a couple of things. I mean, I think this is a good opportunity for us to kind of learn from one another as to how, ultimately, when we think about transportation networks, they can involve humans, they can involve animals. And so ultimately, the framework that we have using network analysis and spatial analysis can be adapted to the pathways of animal trade, for example, and the movements of animal products and so forth as they are distributed. So I think there are certainly opportunities there. The way that we have been imagining this is to date we have focused on human populations, as I've identified. We have seen an interest from the animal sector on things like African swine fever, and perhaps are humans transporting animal products that potentially could be relevant and important. As we highlighted, we are working increasingly with mobile device location data, nearly 400 million devices around the world, to understand. We could even assess and see how movements of populations are going from airports into farm country, for instance. So there are many different ways that we can actually analyze these data to understand where there may be introduction of a particular animal pathogen that could trigger an outbreak. But I think also understanding the supply chains of how animal products and how animals themselves are moved between countries for the purposes of trade, from a food standpoint. These are all data sets that we haven't historically tapped into. We do have a number of veterinarians on our team. Largely, we've been focusing to date on zoonoses of animal pathogens like avian flu or swine flu, et cetera, that could then subsequently infect humans. But I think this is really just largely the ability to integrate additional data from the animal perspective. I actually don't think there is anything conceptually that difficult. It's just a technical aspect of tapping into some of the data sets that are particularly relevant to your community. And so we think that the underlying framework that we've built is, again, to my last point, is transferable and can be adapted to use cases that are relevant to the animal health sector.
You just mentioned mobile phones, and there are some questions about that, because you were pointing that as an important thing. And so the first one is, and I will put all in the same bucket. Now, the first one is, well, looks like mobile phones, they will be the new detectors of disease, and this is a good tool. This is a question. And the second one, and it's related to privacy. So I think that they are two questions that could be related, no?
Yeah, absolutely. And first of all, let me just say, I think the issue of privacy is one that we're very sensitive to. So I do want to underscore first of all, everything that we have been doing in terms of analyzing these data are following and adhering to all of the privacy legislation and all of the regulatory frameworks around privacy. I will say much of these data have been used for years before COVID-19 and the current pandemic, around things like transportation, the transportation sector, even the retail sector, marketing and advertising, urban planning. So a lot of these data sets have been used in the past. I think they perhaps just there hasn't been as much attention to them as has come about during COVID-19. So we're very respectful of all of the privacy considerations. We have a whole series of internal guardrails of how we manage and work with these data. All of the data are aggregated. We never analyze information and report on anything down at the individual level. It's always aggregated by place or by time in a manner. And again, keep in mind, I'm a professor and a scientist, and I've been, doing research for my entire professional career, where we have to make sure that we are mindful of privacy considerations. So we aggregate and roll up numbers that you would not be able to identify any individual. And if they're in remote areas, then we have to aggregate them to larger sizes so that they are, again, not identifiable. I do think, however, that there are ways that we can derive really meaningful insights to protect people's lives and protect livelihoods while still protecting privacy of the individuals, to be using the data in aggregate rather than using them at the individual level, or at least reporting at them the data at the individual level. To the other comment around, these are the ways that will stop outbreaks. Well, I do think that there's a lot of utility and a lot of value in these types of technologies, particularly for bidirectional communication, which is what you see we're really trying to do. Is how can we deliver a personalized insight that's relevant to you, and perhaps you can also share some information that is going to help protect the next person. If you think about this piece of technology, Waze, you may have heard of this company. Waze is, I think Google acquired them, but it's like, their motto is outsmarting traffic together. So if my location becomes usable, then you know that there's a traffic jam ahead and maybe you can go in a different route. It's kind of the same underlying principle, but we need to operationalize it. And this is kind of the underlying mindset of our approaches. We can help empower individuals to take actions to protect themselves, but perhaps as we understand their view of the world, what's happening in the world, in aggregate, those insights can be used to protect populations and communities, and potentially even the entire global community. So it has to be done delicately. There has to be a lot of thought and sensitivity around privacy, but I do think it is achievable, and this is something that we take very seriously.
That's nice. Well, according to considering that you are from Canada, so there is a couple of questions that I will also mangle here. So the first thing is how you can, in which way you were contributing to help Canada to stop that. And the other question was if there is any other government that currently they are using this early warning system. No? If so, how, and if not, what will be needed to be done in a good way? No.
Well, ultimately in Canada, I guess what I would say is we were for 7 years just kind of heads down building away our platform. I will say that prior to COVID-19, it was harder to get engagement from government agencies because largely people, I'll just be candid and say, we're like, yeah, that's very conceptually interesting, but it's never really going to happen. What we have been fortunate to do is to be able to work with the government in Canada, where we are supporting not only global surveillance of COVID-19, but global surveillance of other epidemic threats, an understanding of the potential for introduction into Canada, and also using mobile device location data to understand, again, anonymously, where there are areas of risk of introduction. So for example, there are mandatory 14-day requirements for home isolation or home quarantine, I should say, if you've just traveled from an area with lots of COVID-19 activity, let's even say south of the border in the United States. So to understand, are populations following the 14-day home isolation? Are they not? How is that playing out? So there have been a number of different ways that we've been able to support the government, including understanding where local outbreaks are happening, perhaps how they got started, how they may disperse. So there are multiple different ways that we have been supporting the government, not only in public health at a national level, at a provincial level, and even at a municipal level, because every single entity has a different set of needs. And we've been supporting not just public health, but the Department of National Defense as it relates to force protection. So there have been multiple different branches of government that we've been able to support. We are operating in about a dozen countries today, but ultimately, we're 70 people, so we're a relatively small group. But ultimately, our aspiration is to be using this to be empowering and supporting governments around the world, to be empowering and supporting private enterprises. I'll give you an example. Some of our clients are major commercial airports and commercial airlines. If they're empowered with timely information, they can be also preventing the spread of disease. So this is where as I was saying, we need to be thinking not just about the public sector and government, but the private sector and the healthcare sector and the broader public itself. So we are continuing to try and build and engage and support. I will say we are deeply oriented around social impact. I founded BlueDot not because I was looking for another job as a, in addition to my role as a professor and as a practicing physician, but because ultimately we wanted to have impact that we felt was really urgently needed.
According to what you were mentioning as well, no, and I will group also this question because I think that they have some relation in between of them. So the question is, what are the potential dangers of the global warning system, or how does one distinguish between something that is a threat or it's not a threat? No.
Yeah.
And maybe just to add that, because and I think I like this question as well because, and I put it in the same place because I think that could be answered. No? If not, you can decide to split them, doctor, please. So no, this one is the experience when you are disclosing information about outbreaks. No, so in which way there is that there is an economic damage, and in which way that's something that may give some delicate information.
Yeah, no, thank you for that. And it's a really I'll tell you a couple of things. One is, first of all, how do we try and separate news of actual outbreaks from news that might not be real? First of all, we are using artificial intelligence to be able to process vast amounts of information, but we've always felt that artificial intelligence is there to augment and enhance human intelligence, not to replace it. So just as an example, for every single outbreak that our AI picks up, it is presented to our team of physicians, epidemiologists, veterinarians. So they review it and we qualify. Is this a plausible threat, or is there something unusual about it? So we occasionally see things that we look at, and I hate to use the word fake news, but the term, but essentially we look at it and we have some concerns that this does not seem like it is right. So for instance, a while back we saw something reporting on yellow fever in India. Well, yellow fever has not been in India, and if it was in India, it would be a very big problem. So before we just go and report on it, we actually go and try and corroborate it and get additional information. And so this is where the human intelligence starts to come into play. And I think it's the combination of artificial intelligence and human intelligence that gives us the best chance to be able to say, this is not real, or this is real. Now, the other thing that we do also highlight is, where did the information come from? Did it come from an official report? Did it come from the media? Did it come from a healthcare or someone in the healthcare community or public health sector? So that the users can then interpret, well, what is the level of confidence in this? Because what we're trading off is timeliness versus verification. If we wait for it to be officially reported, we might be waiting weeks. But if we want to get it in a timely way, we want to present it, but we want to put the caveats around it. Look, we're going to present it to you. It's not been verified yet. It is still, it is still just, I hate to call it a rumor, but it is a report, but it has not been verified. And we will continue to follow the information and keep digging and make sure that we get the latest information to you. So that's how we've tried to manage. And then ultimately, as it relates to reporting, I totally understand you don't want to be disseminating information that can end out causing fear or panic, and that is not our approach. But what we're trying to do is report in a timely way, put the appropriate context around it to say, look, this has not been verified yet, but you should probably at least be aware of it. And as more information comes in, we will then start to comment on it. So what we're trying to do is increase access to timely, meaningful information, but do it in a way that is mitigating an overreaction, because there are risks to underreacting and there are risks to overreacting. And we're trying to use the data and our own subject matter expertise. We're not just a bunch of data people that are just throwing this here. I've spent 20 years in this field, and many of my staff also have similar backgrounds. So we're trying to really bring the appropriate measured context to each one of these events.
I think that this is excellent, because I even answered a question that it was already there, because the question was related to this human-machine interaction, no? And you were mentioning how important. Let me explain an anecdote, something that happens to my daughter. We were in holidays, and I remember that she told us, "Look, today we could not get out because it will be raining." And I was looking outside and say, "It's not raining." So you know, now these predictions, I tell you a lot of things, but this human still being an important thing. So I think that you were pointing a nice point as well, no? So there is another question with COVID-19. This is the two last questions, no? With COVID-19, because we are almost out of the hour. So with COVID-19, the travel use, the travel as use has to be stopped, no? So can we assume that airline travel will reduce or will be different? And considering that you have this experience with that, and how will this impact predictions of disease spread? So that's two things that they are also linked together, you know?
Yeah. So a couple of things. You know, I think 2019 was probably the pinnacle or the peak of global commercial air travel. And it's going to be quite some time, I think, before we start to see the same level of travel as we did in 2019. So it will perhaps have an impact in terms of at least minimizing or reducing the amount of potential for dispersion of infectious disease. Just to put it in context, we analyzed the 4+ billion flight itineraries of travelers a year ago, and we traveled over 7 trillion kilometers on Earth that year. And so that's, just to put that in perspective, that's about 25,000 round trips to and from the sun. So this is a lot of travel that we did on airplanes. So we can move microbes around quite a bit. 2020 and I think beyond, it's going to take some time for travel to start to you know, gradually increase. But we are seeing, because of the economic considerations, we are seeing a reopening of travel. It is all happening. And we are using very, very the latest and most granular data. So now we're looking, instead of looking at flight schedules, let's say on a weekly or monthly basis, we're actually gathering data on a daily basis to see, because this network is now so dynamic, it's changing so quickly, that we are trying to keep up with all the latest data on how flight patterns and so forth might take place. What we found in the past was, generally speaking, year over year, the world's air travel may have increased in volume, but generally speaking, the seasonal patterns tend to be very similar. We tend to travel more or less in the same kinds of ways. Of course, with COVID-19, air travel has been massively disrupted. So what we're doing here is getting very, very current and up-to-date data across the globe to make sure that our predictions are as close as possible to you know, to what's actually taking place. So hopefully that gave a little bit of a sense of how we're thinking about travel in the short term, but also in the mid to near term.
Sure. Well, I think that we are almost out of run out of time, so I think that we should stop. But having you around, I couldn't avoid to make the two last questions that they are coming,
Sure.
And they were the first ones. But I keep it as the last ones, no? So the two last questions are when a new pandemic will occur, and the last one is where will occur. So sorry for that. I know that, but well, they were there. So
yeah, well, I'll answer those quickly because I know we're short on time. When the next pandemic will occur, it's anyone's guess, and where it shows up is anyone's guess. What I would describe us as not having the crystal ball about where the next thing is going to come. I would describe us as like a really sophisticated smoke detector, so that, you know, we are there to pick up that early signal and provide that early warning. And during COVID-19, we've also been a bit of the fire extinguisher in helping to kind of put out some of the fire and mitigate transmission. But ultimately, where and when this occurs, maybe the point that is most pertinent is that, as we know, about 3/4 of all emerging diseases in humans have their origins in animal populations. So if we want to try and prevent, and it's important for us to reflect and think upstream about how these things get started, I think we need to be considering and thinking about disruption of wildlife ecosystems and how that might put humans in contact with populations in wild animals, and really ultimately just how we are interacting with the world around us, and how this is perhaps being the catalyst and trigger for the beginning of these epidemics, whether it's HIV or SARS or the H1N1 flu pandemic or Ebola. I mean, these are diseases that have their, or COVID-19. We don't necessarily know which animal yet, but all of these tend to be originating in animal populations. So I can't tell you where and when, but I hope that we use this as an opportunity to reflect and think ultimately about how can we create a safer world, not just by thinking about early detection and response, but actually be thinking even upstream about how can we better prevent the appearance and the emergence of novel pathogens. So maybe I'll end there, and just also want to thank you for the invitation to be a part of today's forum.
It's been a great pleasure, and I think that what you were mentioning now, it goes through One Health, which is a concept that we really support. We really like it. So I just have the chance to say thank you again. Thank you very much, Dr. Kamran Khan, for this excellent and really very didactic presentation that helped us a lot to understand, and today to be a little bit more clever than we were yesterday. So thank you for this nice presentation. And with that, I want to also thank you, all the audience, to be there. And it's been a pleasure again to give to all of you a new session of information. So thank you very much and have a nice day.
Thank you.